So warm welcome to everyone. My name is Yong Kian. I'm a scientific officer at the Center for Outbreak Preparedness. First of all, I would like to thank everyone for spending your Thursday afternoon with us. The title of today's webinar would be The Global Status of Monkeypox and How Asia Can Be Prepared, hosted by the Duke NUS Center for Outbreak Preparedness. As a brief background, the center was recently launched actually in June this year and was really set up to enhance regional health security through capacity building of infectious diseases surveillance systems, increasing development and access to novel diagnostics, therapeutics and vaccines, and also to strengthen health system readiness and of course, to build an enabling environment for all these processes to thrive. So in light of the global outbreak of monkeypox, with cases crossing over 50,000 and detected in more than 90 countries now, the WHO has recently declared it as a global health emergency in July. Recognizing the public health risk it poses, we are hosting this webinar to really have a discussion on the current status of the outbreak. What are the past experiences of previous outbreaks, and what are the lessons we can learn to prepare ourselves further in this region? So the webinar will start with a keynote presentation, followed by a panel discussion and a Q&A. So I'd like to introduce our keynote speaker, Dr. Pushpa Ranjan Wijayasinghe, an epidemiologist and a consultant in community medicine. In his current role, he's a program area manager for infectious hazard management at the WHO's Health Emergencies Program in the Southeast Asia Regional Office. Dr. Pushpa leads the health operations pillar and is also the incident manager for the monkeypox response and the alternate incident manager in WHO CRO's COVID-19 response. He's responsible for coordinating the preparedness, response, and also the networking for risk profiling, risk assessment, risk mitigation, and risk prevention for national and regional health security in WHO CRO. So without any more delay, please go ahead, Dr. Pushpa. You may share your screen and start your presentation. Thank you.
Thank you, Ko. I think you can see the presentation, right?
Yes, we can.
Okay, very good evening, distinguished participants, panelists, and colleagues. It's my extreme pleasure to update you with the global monkeypox situation and declaration of it as a public health emergency of an international concern, or in abbreviation, PHEIC. Colleagues, the first human case of monkeypox was identified in 1970 in the Democratic Republic of Congo. Since then, human cases have been reported in 11 African countries. The disease is having a global public health significance beyond Africa. The first outbreak of human monkeypox was reported in the United States in 2003. Since May 2022, monkeypox has been detected simultaneously in multiple countries where cases have not been previously reported. Against this background of the ongoing transmission of the disease in multiple countries where cases were not reported previously,
Sorry, Dr. Pushpa, can you put it in full screen mode? I think we are not seeing the progression of the slide.
Okay, so yeah. I can see.
Because we're seeing only the first cover slide.
It's not moving, right?
Yeah, it's not moving.
Why in my screen I'm seeing the full screen. Kun, I will stop sharing. Can you share it from your end? That would be better.
No problem. Yep.
Can we go to slide number 3? Thank you. So against this background that I was talking a short while ago, the background of ongoing transmission of the disease in multiple countries where cases were not reported previously, the Director General of the WHO reconvened the Emergency Committee for Monkeypox to review the latest evidence and advise the Director General. Though the committee did not reach a consensus, using the mandate vested upon the DG, as per the international health regulations, DG, considering necessary elements of decision-making outlined in the International Health Regulations 2005, declared that the current outbreak constitutes a public health emergency of international concern or PEIC. He also issued non-legally binding temporary recommendations to state parties. That is the terminology which is being used for the countries in the international health regulations, to implement a coordinated response with a view to stopping human-to-human transmission and protecting vulnerable groups. The key strategies in this regard entailed enhanced disease surveillance, contact tracing, risk communication and community engagement, and implementing risk reduction measures. Let's move on to the next slide. Now, criteria and procedures for declaring a public health emergency of international concern has been provided in the international health regulations. PEIC is defined as an event which is determined to constitute a public health risk to other states through international spread of disease and to potentially require a coordinated response. The event being an unexpected or unusual, its serious public health impact, significant risk of its international spread, risk of international trade or travel restrictions are criteria for consideration for declaring a public health emergency of international concern. DG made the decision based on information provided by state parties, advice of the emergency committee, scientific principles and scientific evidence, and assessment of risks to human health, international spread of the disease, and interference with international traffic. So when any disease entity comes to be decided for a PEIC, these procedures are adhered to. Next slide, please. The declaration of the PEIC constitutes the highest level of global public health alert for monkeypox in this case. It enhances global coordination, cooperation, and solidarity between the countries. The legally non-binding recommendations that accompany any PEIC declaration are practically and politically significant in terms of mutual accountability for state parties rather. It sets principles and practice to inform national responses. Some countries, not everybody, but some countries activate their emergency standard operative procedures and emergency management systems based on public health emergency of international concern declaration. Moreover, though it is not necessarily the case, declaration may act also as a trigger for donors to release funds for response in some vulnerable countries. Let's move on to the next slide. Starting from May, but in general, starting from 1st of January 2022, cases have been reported from 103 member states. So this week, one country has been added, a new country, in all 6 WHO regions. As of 12th September, the cumulative number of cases reported to WHO surpassed 57,607 laboratory confirmed cases. There have been 22 deaths reported attributable to monkeypox. The world observed an increasing trend of monkeypox cases. However, starting from 1st of September, the number of reported cases is demonstrating a decline. The percentage reduction of cases during the last week relative to the previous week was 8.5, and the week before relative to the preceding week was something like 20%. So we have been seeing a kind of decline in the global scenario. Next slide, please. Presented are the epidemic curves of the monkeypox outbreak in 6 WHO regions, reflecting the overall global trend of decline in cases. Both European and Americas regions, which were hotspots, have demonstrated a declining trend in cases. Next slide, please. Now, the incidence map clearly shows the distinct spread of the disease in Europe, South and North America, in addition to the previously reported countries in Africa. According to the previous nomenclature, we used to call them endemic countries. Next slide, please. The information in this slide is only up to 7th September. However, during the period of 4 weeks prior to 7th September, 71% of cases were reported from WHO's Americas region, while 28 was from Europe. So 99% of cases reported in the last 4 weeks were from these two regions. 88% of cases were reported from the top 10 countries in the world. Next slide, please. These are the epidemic curves in top 10 countries by total reported cases. The declining trend of cases in most epidemic curves of the top 10 countries in terms of reported cases is noteworthy. Again, it is a testimony to the observed global decline since 1st of September. Next slide, please. As case counts have predominated case-based data, the details have not been, as case counts have predominated aggregated data, the details have not been made available uniformly for all cases. Nonetheless, nearly 99% of the cases where information is available are young males whose median age is 36 years. The primary affected age group is that in the 18 to 44 years age range. The children and adolescents affected are less than 1% of the reported cases. Next slide, please. As far as the profiles of the reported cases are concerned, the ongoing outbreak seemingly occurs mainly among men having sex with men. But what is noteworthy is that for most reported cases, there are missing values. Among cases that reported the status of travel, only 27% had a travel, suggesting that at least 3/4 of the cases where information was available was non-imported cases. Nearly every second case was HIV positive. Next slide, please. Now, while the trend of the proportion of males affected and proportion of male cases who had sex with men remain high and well over 90% starting from July, starting from the beginning. Starting from July, a slight declining trend is observed for both males and males who had sex with males. This indicates the emergence of cases beyond males and males who had sex with men, though the numbers could be still very small. So small scale community transmission has also happened. Next slide, please. Although information has been received only for a small number of the reported cases, sexual encounter has been reported as the major transmission mode. On the other hand, party sitting with sexual contacts has been reported as the setting where exposure is likely to have happened. This indicates the potential amplification sites rather for establishing new cases for transmission. Next slide, please. Let me conclude by summarizing my presentation. Monkeypox, a viral zoonotic disease, has been identified since May 2022 in several countries that are beyond countries where cases were previously reported or endemic countries as per the old nomenclature. WHO formally declared the current multi-country monkeypox outbreak as a public health emergency of international concern, the highest level of global public health alert. The legally non-binding temporary recommendations issued following declaration of the public health emergency of international concern enable a coordinated response by state parties for enhancing readiness, stopping human-to-human transmission, and protecting vulnerable groups. Though globally cases were increasing since May 22nd, a decline has been observed in the weeks starting from 1st September. This needs further observations for clarity. 99% of the reported cases in last 4 weeks were geographically distributed in Europe and Americas regions, while 10 countries accounted for 88% of the caseload reported so far. While the disease was reported mainly among young males in the age group of 18 to 44 years, the proportional morbidity of child cases was very low. Of all reported types of transmission, a sexual encounter was predominant around in 92%, but having taken into account the limitations of data reporting. Of all settings in which cases were likely to have been exposed, the most common was a party setting with sexual contacts. With that, let me thank and hand back to the main control room. Thank you.
Thank you, Dr. Pushpa, for that very insightful presentation. I think it gave a very good overview of the global situation of monkeypox and really highlights the epidemiological features of the outbreak and how does the WHO declaration of global health emergency help in the outbreak response. So if you have any questions for Dr. Pushpa, please use the Q&A function. And for Dr. Pushpa, please feel free to answer them at the Q&A box if you prefer. This is the same for other panelists during the panel discussion too. Okay, to move on to our panel discussion, let me introduce our moderator, Dr. Ruki Diawis, the Deputy Director for the Center for Outbreak Preparedness, and also an Assistant Professor in the Emerging Infectious Disease Program here in Duke NUS. Dr. Ruki is a viral immunologist and vaccinologist by training with over a decade of experience working on infectious diseases. Her research interests include antibody responses, serosurveillance, diagnostics, therapeutics, and vaccines against viral pathogens. She also has a very keen interest in working in close collaboration with local and international partners, including low and middle income countries, mostly in health system strengthening and outbreak preparedness. So over to you, Ruki.
Thanks. Thank you, Ewan. Thank you, Dr. Pushpa, for giving us a really in-depth current situation of the monkeypox global outbreak. Now I will introduce the three other panelists. So we have four panelists, including Dr. Pushpa. We have Dr. Adesola Yinka Ogunwile, who is an epidemiologist at the Nigerian Center for Disease Control, NCDC. She is a 2018-2019 fellow of the African Public Health Leaders Fellowship from the United Kingdom. Adesola has extensive experience in disease surveillance, public health response to infectious diseases. Her research interest includes infectious disease transmission and One Health approach in disease control. She leads the One Health and the Monkeypox Technical Working Group at the NCDC. And as we know, Nigeria has a lot of experience with monkeypox. We're really glad to have her on this panel. Next, we have Associate Professor Pauline Lim, who is the Director of the High-Level Isolation Unit at the National Center for Infectious Disease in Singapore and the head of the Travelers Health and Vaccination Clinic at TTSH. Prof. Lim is the recent chair of the Technical Advisory Group for the WHO Health Secures Interface and the current chair of the Independent Allocation of Vaccines Group for the COVAX facility, and also a member of the Singapore's Expert Committee on COVID-19 Vaccinations. Prof. Lim is a member of the WHO SAGE Working Group for smallpox vaccines and has helped the MOH NCID guidance for monkeypox management and vaccination in Singapore. She also helped identify the first monkeypox case in Singapore, which was in 2019 in a traveler from Nigeria. Thank you, Prof. Lim, for joining us. Then we also have Associate Prof. Tan Boon Huen, who is the Distinguished Research Scientist for Biological Defense Program in the Defense Medical Research and Environmental Institute, DSO National Laboratories. In 2019, she took over as the chair of the Institutional Biosafety Committee to oversee biosafety and biosecurity. Between 2014 to 2021, she was the director of the Biological Defense Program, where she was responsible for the management of R&D activities in biodefense for the Singapore Armed Forces, also developing technical competence in diagnostics, countermeasures for a range of high-risk, high-consequence pathogens. She is a molecular virologist by training and has interest in virology, particularly in detection and characterization of respiratory viruses that are of importance in clinical biodefense and military public health. Thank you, Prof. Tan, for joining us. Again, as we know, a lot of the funding for diagnostics and therapeutics and vaccines that we have currently for monkeypox has come from biodefense strategies. So again, it's very good to have your perspective on this panel. Now, My first question, I think, will be for Dr. Pushpa. As we saw from your presentation, we are seeing globally that cases are coming down. And again, different countries are in different situations of that. I believe Brazil still has quite a bit of cases. But do you think that as we come out of the COVID-19 pandemic, we are better prepared for handling infectious outbreaks such as monkeypox? Do you think that helped?
Yes, Ruki, I think this has to be looked at from two different angles. If you compare the country capacities relative to the 2009 H1N1 pandemic, over the years, especially under the pandemic influenza preparedness framework, countries were investing and partners were investing on certain things, and that really helped countries to stand up for the COVID-19 pandemic. And then COVID-19 pandemic itself was a kind of real-time simulation exercise for actions. So this has really helped countries. Say, for an example, if you look at case detection, surveillance, and contact tracing, quarantining, and then regulation strengthening for medical countermeasures, vaccines, etc. If you look at these, obviously there have been some strengths relative to 2009. But having said so, this is not an issue for us to be complacent. So if you look at if you look at the current situation in the region, there are so many gaps. Now, WHO has coordinated, but countries have led intra-action reviews, and these interaction reviews have provided strength and weaknesses of COVID response. This could be really useful for building the preparedness for emerging infectious diseases in the region in the future. If you look at, countries have systems for governance and condition, even in the COVID. Even the top level involvement has been observed, but now countries need to formalize them for future because they were ad hoc. So, for a future, pandemic, to respond to a future pandemic. So roadmaps, health security roadmaps, diagnostics roadmaps, policies, strategies, plans, and systems, governing mechanisms, coordination mechanisms will have to be implemented. Now in WHO Southeast Asia region, very recently, couple of days back, ministers of health agreed to have a regional council of heads of states to be established so that they get the top level support when an outbreak of this nature happens. And then if you look at the other things, early warning and alert system, yes, we have invested a lot during the COVID-19 pandemic, but we need to have more established systems. Now, I will not go into details because of the time, but if you look at monkeypox surveillance is totally different from COVID. So there are issues. So the point is that we need to think about how to strengthen these systems in the countries. And then the epi capacity is a problem in countries. Maybe capacity is available, but to respond to a pandemic, it is not available. Diagnosis. At the central level, diagnostic capacity is strong, but you go to the peripheral level, universal coverage, and it is a challenge. And then you need to quickly transfer lab capacity to countries if you detect a new pathogen, right? So this is a challenge for the global partners. And then genomic sequencing. Countries have now started, expanding genomic sequencing capacity, but it is still in the infant stage, and we need to strengthen that. So that is it. And then, how to use genomic sequencing data for decision making. And then we know that behavioral science aspects as well as infodemic capacities are lagging behind in countries. In a future pandemic, we have to capitalize on the current experience, and we need to build on. And then we need to have more mechanisms for community engagement and community empowerment. That is, I would say, it is still weak, although we have been using this for COVID response. And then tools and capacities for calibrating public health and social measures, which is very, very important. Countries need training, countries need tools, countries need thresholds, because this is a matter of lives versus livelihood. We know how countries are, suffering as a result of COVID-19 restrictions. The economics are affected. Of course, we need to save lives. At the same time, we need to, save the livelihood. So, there is a long list, but I will stop here. The point is, if you look at, the 2009, we have made one stride forward, and, COVID-19 has helped us to establish and strengthening capacities, but that is not enough for us to respond to a future, pandemic or future large-scale outbreak, future outbreak of an unknown pathogen. And this is where the global partners, as well as countries, regional level partners, will have to work to build these, platforms. Over.
Thank you, Dr. Purshawad, for that very in-depth answer. Actually, that's a good, glad to hear that we have learned quite a bit of lessons from the COVID pandemic. But as you said, there are still areas that we do need to work on, and areas we need to build capacity. Let's take a bit of a step back. This question is actually for Dr. Adesola. So Nigeria actually went through one of its worst monkeypox outbreaks between 2017 and 2020, I believe. And you were part of that outbreak. You were actually part of the outbreak investigation on the ground, in the field. Tell us your experience from that outbreak, and what were the main challenges back then, and what worked, what strategies worked, what didn't, and how does that outbreak differ from the current outbreak?
Yeah, thank you so much. I'm glad to be part of this discussion. So before I continue, let me just say currently not the lead for the monkeypox and the One Health, as I'm currently on an extended leave for career development away from the NCDC. But I continue to be part of the team and continue to support. So in 2017, there was a resurgence of monkeypox in Nigeria, which actually started at the end of September. Precisely on the 28th of September, the NCDC was notified of a suspected case of monkeypox in a tertiary institution in Bayelsa State in Nigeria. Now, so this case was investigated, and because of the high index of suspicion that this case is likely to be a monkeypox case, we didn't stop at investigating that case, just that case. We actually went ahead to start to sensitize the entire country to know this suspected case we're investigating. And so please, if you find similar cases in your state, in your health facility, please report. And so before that, before this suspected case, important to know that for 39 years, there wasn't any known or reported case of monkeypox in Nigeria. And that implies that there was no surveillance system in place. There was no, in fact, it wasn't listed as one of our diseases listed for priority. We have over 40 diseases of public health importance that we do surveillance for. It wasn't. In fact, at that point, WHO Afro region had didn't have monkeypox as a priority disease. So it was after this 2017 case that a lot actually came on board regarding monkeypox surveillance in that region. So the investigation went ahead, and we're able to, before we were able to confirm the index case, I can tell you we had discovered several other suspected cases, in many cases because of the surveillance that we enhanced surveillance that we started at that point. So at the time we were having confirmation, confirmed cases were already, we already had confirmed cases in multiple countries, in multiple states at that time. So also suffice to say that we didn't have laboratory capacity to make that diagnosis. And so that was a big problem for us because we have to send samples outside Nigeria to make the diagnosis at the time, sent samples to Singapore, to the US and all that. So eventually we're able to confirm this, and we started, we continue with the surveillance, enhanced surveillance system, which was in place. At most health workers, the members of the public, were not aware of a disease called monkeypox. That's also caused a lot of tension among members of the public, and that led to some stigmatization of monkeypox cases, both from members of the public and healthcare workers in particular, because people weren't sure of what the transmission, the severity of this disease. So we had a lot of challenge managing panic and managing stigmatization at the time. But all this, amidst all this, we were able to put the surveillance system in place as a country. We also developed capacity to be able to make the diagnosis in country within about 6 weeks. Then developed a guideline, which we published. And then with that, we started monkeypox surveillance in Nigeria, and that has continued till date. Like I mentioned, challenges, a lot of challenges regarding stigmatization, regarding making diagnoses. But we were also able to add to knowledge, because since that time we have made a lot of recommendations. We're able to describe the epidemiology of monkeypox in Nigeria, part of which is currently what is being experienced in other countries. That was at the point where we're able to demonstrate that, unlike what was previously believed, these monkeypox cases are not only seen in remote rural areas, we're seeing them in urban settings. And perhaps that's part of what contributed to the exportation of cases that we saw from Nigeria. And then we also were able to demonstrate male preponderance of monkeypox cases since 2017, and the fact that a young male, a young adult between the age of 20 and 40 were most affected. So what we're seeing now are things that we reported with our findings since 2018. Now, the challenge, now we've learned a lot, and I think it's important. One of the things that worked for us is the fact that at the point we have the Nigerian Center for Disease Control as an institution, public health institution, and we had that the collaboration with states. I know that some of the challenges some countries are currently having has to do with data sharing within countries and globally, and you can do very little if you do not have data to work with. So, but I think we enjoy that collaboration from our states, sharing their data with the Nigerian Center for Disease Control, with which we're able to develop our surveillance system and all that. Then part of what also worked was the fact that we have the pool of trained healthcare workers, and we also have experience in infectious disease response. We've had several diseases, infectious disease outbreaks, and which we have managed. So we have that experience to be able to help at that point in time in developing a strategy and developing a control strategy to a re-emerging or a totally new disease that we were experienced at the time. What didn't work? We were not able to vaccinate. Basically, one, we have issue with access. We didn't have the vaccine, even though I know there were discussions around that time. But even if we've had the vaccine, there's also the point that who are you going to vaccinate? Nigeria is a very large country, and the epidemiology of the monkeypox in Nigeria was such that it covered quite a large geographical area, different groups, unlike what we currently have, in which we have men having a group, we have men having sex with men being largely affected, which makes it a bit easier to target, but in the case when we have from 2017, the epidemiology wasn't that clear. The route of transmission was not well known. So it was a challenge for us. There was a need for us to do research. There was a need for us to understand the outbreak at the time in order to be able to develop a control strategy. And that is currently ongoing. I know that we're saying globally the cases are on decline, but I know that I don't agree that that is the case in endemic country. If you look at the EPICOR from Nigeria, the last station report from Nigeria, there isn't declines. In fact, in 2022, we've had more cases reported than we've had since 2017 in Nigeria. And we are not seeing a decline in the number of cases. We are seeing other places in Nigeria that were not affected in 2017, 2018, being affected in 2022. So there's still a lot to be done. I think part of what we did then, like you talked about One Health, was for us to bring in One Health approach to the monkeypox response in Nigeria. In fact, by the time the laboratory diagnosis was being made for human diagnosis in human, when our team were being trained to make diagnosis in human, at that same time, the animal component team were also trained to be able to make diagnosis in human. So animal surveillance also is ongoing in Nigeria as well. So it's One Health approach to the response to monkeypox outbreak in Nigeria. Okay, so I think perhaps I may stop here. I'll take some questions if we have.
Thank you, Dr. Adesola. I mean, it's quite nice to hear that the lessons that you learned in 2017, right, has prepared you for the current outbreak. And it's also nice to hear that some of the features of the epidemiological features of that outbreak and now are similar, although there are some differences as well. I'm going to pick on this One Health since you brought up the One Health concept, and since I had posted before. So I'm also going to bring up an example. So in 2003, United States had a shipment of rodents from Ghana, right? They were infected with monkeypox, and very soon there were pet prairie dogs infected. And very soon, there was an outbreak of monkeypox in the US, over 70 cases. Now, this really does highlight the huge potential for zoonotic transmission for monkeypox. Now, in the current outbreak, there are a lot of scientists, a lot of countries are finding monkeypox in their sewage, right? And obviously rodents can pick it up. So is there a worry? And this, anyone on the panel can answer. Dr. Adesola, you can go first. Is there a worry that countries that didn't have monkeypox that as endemic can now have it as an endemic pathogen?
Yeah, thank you for the question. So currently, we now have evidence of reverse zoonosis for monkeypox in the ongoing outbreak. But in addition to that, we have the so-called endemic regions where it is believed to have primary transmission, as in primary zoonotic transmission, and human-to-human transmission. I think it is safe for us to manage these two and respond to these two simultaneously, because we have evidence of zoonotic, primary zoonotic infection. The ongoing multi-country outbreak is largely human-to-human transmission driven, but we know that both can coexist. So I think the approach is to ensure that every country are responding to both, responding to this outbreak to tackle the human transmission, as well as managed as much as possible the primary transmission from animal to human, while doing as much to prevent the reverse in transmission to human. I know that from the literature, one of the reason for cessation of the smallpox vaccine was the belief that monkeypox is unlikely to persist in human population. So it is a good time for us to perhaps think around that now, because the rate of human-to-human transmission we're seeing is more than what used to be known, and also the I think we have more evidence of human-to-human transmission than animal-to-human. And so there's a need to tackle both currently. Over.
Right. Thank you. And I think Prof. Lim has her hand up. Please go ahead.
Thanks. I just wanted to jump in on the One Health question. I think that wastewater surveillance is interesting and useful, but one of the challenges, of course, is that when you're detecting, genetic fragments in wastewater, you actually don't know whether it's a viable virus. So that's part of the challenge. Certainly the idea of rats in sewage, picking up, monkeypox. I mean, we've certainly got quite a rat population in Singapore. So that would obviously be a concern. And then the One Health side of things, which is sort of somewhat ironic, is that, it jumps from animals to human, but now potentially also from humans back to animals, as you've seen with the report of the dog that got infected from its owner with monkeypox when they were co-sleeping. So once it gets the issue about mutations and persistence in terms of being endemic or enzootic is really a numbers game and a transmission game. So once there is large numbers of cases, then the likelihood of mutation, viral mutation, and variants emerging will then increase. Just it's a mathematical thing, and so I think that's going to be part of the things that we have to do with molecular surveillance. Thanks.
Right. Thank you. Thank you for that. And I think Dr. Pushpa has his hand up.
Yeah, I have nothing much to add because panelists have added, but I just wanted to make few points. And Ruki, as a specialist in this area, so UK has done, from 2007, they have analyzed genome sequences, and what they have found is that from Africa, there have been several infections. That means from zoonotic origin to humans, and they have been in transmission, and we saw these outbreaks in UK, USA, Israel, etc. before this multi-country outbreak. And genomic sequencing, pattern, they show they are distinct, but the point is that they have, come from animal sources, and then they have been transmitting. But what happens is, due to many reasons, due to many hypotheses, that 2022 multi-country outbreak has now happened, and as the things stand right now, it is being transmitted among humans, and especially predominantly confined to a particular group. That's one thing. But at the same time, as Prof said, there is the possibility of reverse infection from human to animals. But at the same time, the point is that the new infections from animals to humans will also happen. And from there is a possibility, spillover will happen, and from there onwards, there is a possibility of being transmitted. And if you look the transmission right now, what we see is that, this super spreader event is associated with the particular lineage. And now we were seeing in Thailand, the cases were not linked to that particular super spreader event in, in Europe. It was related to the transmission that was happening in the US. So this shows the importance of One Health as well. I just wanted to highlight that. Over to you.
Thank you, Dr. Pushpa. So as both Dr. Pushpa and Prof. Lim has brought up mutations, right, in monkeypox, and each time there is a zoonotic jump, when there is increased transmission as well, it's collecting mutations, these viruses. This is actually a question for Prof. Lim. So this monkeypox strain that's circulating now, right? Are there any disease, in terms of disease, are there differences in the disease presentation that's going on with the current outbreak? That's one question. And second is the current strain, as it's collecting mutations, are the vaccines as protective against it? So I know the current vaccines we have right now are actually against smallpox, right? That we're using, because we're using this cross-protectiveness of a smallpox vaccine against monkeypox. Are they just as protective? So those two questions.
Thanks very much. As a clinician, I will say that, there's always a spectrum of disease in humans. So it's hard for us to know whether the differences we're seeing are because, we're just seeing, thousands of cases globally, as opposed to, the cases that were originally described in Nigeria, Ghana, etc. The second possibility is differences in transmission route, because if the exposure, for example, to rodents was through ingestion, whereas now some of the cases we've seen, a lot of the lesions are in the perianal or genital area. So that would suggest a potential initial inoculation cutaneously in those areas, either by intimate or sexual contact, and then potentially a secondary sort of viremic spread to distant locations, face, hands, etc. So some of that, it's hard to know in the beginning which one explains that. And then thirdly, of course, most of the transmission currently happening is what was called the West African clade. So again, there may be clade to clade differences. So hard to tell. And then obviously, if it's hitting an immunosuppressed population, we know that opportunistic infections in immunosuppressed people can be much more severe versus in well-nourished persons. So there are those kinds of challenges, hard to say. On the vaccine front, I would say that we don't have a monkeypox vaccine. We have smallpox vaccines, which we are deploying for monkeypox. ACAM2000, which many of us, who were born before 1981 got, we still have the scars from it, is quite a nasty vaccine with lots of side effects in some ways. But it's the best that we have. And then, of course, there's Jynneos, which is the third generation, vaccine from Modified Vaccinia Ankara, MVA. So it's estimated, but there isn't really a lot of data in humans. So we're sort of putting together a bunch of PICO questions, questions that we'd like answers to and data to. But that data is really not currently, readily available. So we're trying to sort of focus the efforts of research groups around the world on those kinds of questions that would help us, take care of patients and, develop better, sounder policies. So the vaccines basically are estimated at maybe 80–85% effectiveness. But again, the unknown questions are, is someone vaccinated less likely to transmit if they have breakthrough infection? Are they less likely to get severe disease? I mean, we hope so. We think so, but it would be really nice to have data. And then I think the other question is that the most vulnerable people can't take ACAM2000. So persons who are pregnant, persons who are severely immunocompromised. So in this case with Jynneos, it would be really helpful to understand if there's reduced protection, for example, in people who are immunocompromised, what that degree of reduction in immune protection would be. And then the long-term question is, how long does protection last? Thanks.
All right. Thank you, Prof. Lim. Prof. Tan has a hand up. Please do jump in.
Hi, I just want to add on to what Pauline has stated, that actually one of the differences with this current monkeypox outbreak is the human-to-human sustained chain. I mean, it's gone up to about 7 to 10 per person in a chain, and I think that is very unusual. I think in the past, it's probably just very few, like one human-to-human ratio, or even from the peri-dog to the human, and you don't have such a widespread of secondary transmission. And I think this is one very unique characteristic of this current outbreak. And I want to add on that actually surveillance is very important, whether it is human surveillance or whether it's going to be animal surveillance. I agree absolutely with Dr. Adesolo, that is very, very important. And, I also agree with Dr. Pusha that doing genetic surveillance is equally important, because I understand from the current outbreak, there is already multiple lineage that are emerging. And I know that there's a group of scientists in the States that are actively doing whole genome sequencing. And today they have identified up to about 40 genes that are different among the clade. Not too clear what is the difference among these, because there are some parts where the genome are relocating to other parts of the genome. And again, this is worrying because it could be a transmission risk, and it could be the reason why the transmission is sustained in human to human chain. So that's my contribution.
Actually, Prof. Tan, I'm going to pick on that surveillance you mentioned. And the question is, I mean, you have a lot of experience with diagnostics and R&D. And when we have these re-emerging pathogens into new locations like Asia, right? We don't usually see monkeypox in Asia. What are the current diagnostics for monkeypox, and are there newer, faster, rapid diagnostics? Are we prepared to do we have good diagnostics, basically?
The current diagnostic for monkeypox is still based on molecular biology methods. And I think we can see from the COVID-19 that molecular biology methods is still by far surpass any other methods other than art. But you know, where art is not as sensitive as molecular biology methods. Now, in the case of monkeypox, so far, if you look at the laboratory testing, we have monkeypox specific assay. But I also understand that because the current monkeypox lineage is going through mutations, and I've learned that some of the mutations, they have deleted gene targets. So you do need to use more than one target gene when you're doing monkeypox testing. And another method that the laboratory are employing is to use a pan orthopox virus assay to detect as well. In case you missed out on the monkeypox specific targets, then you have the other targets from the orthopox genes that are conserved with the monkeypox that can verify for the presence of monkeypox. Maybe a bit difficult to look at antibody or antigen detection because the viremia stage is quite short. Maybe Pauline can correct me, but viremia stage is quite short, so I'm not sure how we're going to detect that from the blood. But then if some of us have been vaccinated with the first vaccine, then we will be responding, and that may give the wrong results that we want for testing of the monkeypox virus. So molecular biology assay is still by far is still the best.
Okay. I think Dr. Adesola has her hand up. Please go ahead.
Okay. Yeah, thank you. So I kind of have this concern based on the assumption. Well, perhaps maybe if we don't want to agree, it's an assumption of the transmission of monkeypox in Africa. It seems we based on available evidence that is believed is mostly zoonotic. I especially have pushing this to Dr. Pusher. Pushpa, there's a need to look, especially from WHO, the coordination, to perhaps do more. From available work done in Nigeria, including genomic studies, we seem to have more human-to-human transmission. And unless we're able to appreciate this, so that we approach the control as such, we feel we're having more of primary transmission of monkeypox in Africa, which the approach to the control definitely is going to be different. But from the work we've done in Nigeria, I think we having human-to-human transmission driving the outbreak in Nigeria. From the publication in 2019 in the Lancet, part of what we published is that evidence of human transmission ongoing in Nigeria, and more recent work which are being under review for publication is showing further evidence of human transmission in Africa. So I think it's important to not just think the multi-country outbreak going on in the Western countries is human-to-human transmission, while Africa remains more zoonotic. I think we need to look more into that, so that can influence how we approach the control in those places. Over.
Dr. Pushpa, would you like to comment?
Yeah, I think she made the point, the very right point, because now there are two approaches here. As we said, the human-to-human, 2022 outbreak, which is confined to a particular risk group at the moment. Of course, we see, beyond that network as well, but predominantly in that. So here, the approach is different. But as he said, even if we contain this outbreak, the spillovers from zoonotic sources, animal sources to humans will continue to happen in countries like countries in Africa and other settings. So as he said, I mean, we need to have different approach there for detection and prevention, as well as highlighted genome sequencing and trying to understand the molecular epidemiology, as well as the epidemiology of transmission, etc. So that is one set. And then the second set is the one where the current, outbreak is happening. I think it's a real great point. And I just want to add, a couple of more points in relation to vaccines also, since it was touched upon. Yes, obviously right now the issue, I mean, there are 3 vaccines like MVA-BN, the Bavarian Nordic vaccine has been approved in Canada, EU, United States, Republic of Korea and Singapore. And then LC16 has been, approved in Japan. And then LC16 is a 3rd generation vaccine, and Bavarian Nordic is also 3rd generation vaccine. And then ACM 2000 has been approved in USA under emergency investigations of new drugs protocol. So the point is that WHO has also highlighted where in the temporary recommendations where vaccines are available to use vaccines. But one point has to be made, as mentioned by Prof. These vaccines have been developed and tested in animals, because they were, related to smallpox. So therefore, the point is that at this point, these vaccines have to be given under the so-called monitored emergency use of unregistered experimental interventional or MURI protocols, or what we call in loose compassionate protocols with standardized collection of data. So I mean, this is the point. And therefore, and on the other hand, the vaccine availability is very limited at the moment. So therefore, we think while vaccines are important for pre-exposure and post-exposure prophylaxis, however, we need to pay more attention on public health and social measures or other public health interventions without giving too much prominence to vaccines due to all the factors that are there. With that, let me hand back.
Thank you, Dr. Pushpa. So that reminded me, Asia. So Asian context, we obviously there's not enough vaccines to go around. Asian countries, we don't have monkeypox is endemic, so there's no prior immunity. Smallpox vaccine immunity is waning. Also, it's an older population that prior to 1981 that Prof. Lim mentioned that got the smallpox vaccine. What can Asia do to prevent? And maybe we've touched on these things, but since this webinar is also about what this monkeypox outbreak means for Asia, how can we be better prepared in Asia? I think I'll first, maybe anyone can jump in, but maybe Prof. Tan can comment, then Prof. Lim.
Well, in the first place, I'm not sure if the cases are low in Asia is due to the fact that we're not doing reporting correctly, or we're not doing detection correctly. So that is something that we probably need to take into consideration. Now, how do we stay vigilant? I think the way to do that is to form very strong network among the countries in Asia. For example, I am aware that the defense ministry of each country in Southeast Asia, they actually have a network called the Chemical, Biological, Radiological Network. And this is actually supported by the defense in each of the countries. And this network actually helps to formulate a very strong network in this community, so that we can look at preparedness plans for any emerging biological infections, not only biological, but also chemical as well. But again, the other network will be the WHO network, which we are also fairly strong among the public health laboratories. And I know that in Singapore, our Ministry of Health is plugged in very closely with WHO. And again, I am sure maybe Pauline can also contribute something to this. So other than these formal networks, the other informal networks are among the scientists themselves. So we know who are our colleagues in the other counterpart who are working in the respective area. And again, we have this informal network that we do a lot of scientific exchange. And one such platform will be this current web seminar. Yeah, putting people in connection with each other.
Ruki, if you permit me, let me give my perspective
Yes.
from the WHO.
Go ahead,
And,
Dr. Pushpa.
Yes. So when you look at Asia, and what we need is, and as you said, as we don't have spillovers from animal sources, one way of getting this is through importation from affected countries, and then it has to be established. It has to be established means chains of local transmission has to be established. So right now the threat is from importation, and then establishment of chains of transmission within countries. So from this perspective, two things are important, as Prof said. One is detection of cases that are being imported into the region, and then the second one is if there will be established new chains of transmission, ability to detect. Now here there is a challenge. Of course, there are two few things. One is that, as again our clinicians in the panel mentioned, one is the uncharacteristic manifestation of symptoms, and second thing, in contrast to COVID, these patients seek care at dermatological clinics, sexual health clinics, HIV STD clinics, which are traditionally not surveillance sites in our region, right? So we very rarely use these clinicians, sexual and reproductive health clinicians, dermatologists for our surveillance. So countries will have to use this network to find out. Then the next point is we have so many PVRAS cases, differential diagnosis. That is a challenge to some countries, and some setup when, especially if it is going to be the peripheral setups, right? And then, as somebody said, the diagnosis has to be, confirmation has to be done once you suspect, right? So a suspicion, confirmation is there. And then the other point that I would like to raise here is, in Asia, a stigma towards some specific group is very prevalent, and this stigma will prevent clients from seeking care in these specific settings. So they will not be receiving care in a dignified manner. So this will shut down people making access to the centers, and that would help if if they are going to persist, and if they are going to go with the activities, and there is a risk of establishment of local chains of transmission. So this is something that we need to think about. And then the behavioral differences. We do not know whether, if you look at Europe, mass gathering events, gay parades, etc., they have been the amplifying events. We may be having this type of behaviors, but in Asia, we don't see this type of big events. So this also cut down the risk to a certain level, but that doesn't mean that the risk is absolute zero. And then the other important area is tailored awareness creation and community empowerment. But in Europe, we understand in US that this gay LGBT plus communities are being empowered, and in our region, in certain countries, it's a taboo, and we would not be able to create that empowerment, and that without that empowerment, we would not be able to detect cases. So this is another scenario. So overall, I think we have to capitalize the fact that we don't have big outbreaks, as Prop said, but we have to ensure that this is not because cases are not being reported. But having said that, we have to, assuming that we have no outbreaks, big outbreaks, we have to capitalize on that. So in that front, if we step our surveillance, if we ensure access to reliable, affordable and accurate diagnostic tests and diagnostic capacities, and if we focus on sensitizing and training health workers, especially in sexual health clinics, dermatological clinics, etc. And if you strengthen our risk communication and community engagement, if we build trust and awareness among so-called high-risk groups, in this case, LGBT plus groups, and also if we facilitate timely access to diagnostic and care for them in a dignified manner, having destigmatized, I think we can obviously avoid the situation similar to that in Europe and Americas. Thank you. Over.
Thank you for that, Dr. Pushpa. Exactly on point about the stigmatized groups needing empowerment, especially in the Asian region. We have only a few more minutes, so I'm going to ask Dr. Adesela and finally Dr. Prof. Lim to comment. Dr. Adesela.
Okay, thank you. So I think quite a number of my points have just been made, so I'm not going to repeat them. But it's important to emphasize the fact that for preparedness, there's a need for hope to be open-minded. To be open-minded in the sense that, just as we said, surveillance needs to be done appropriately, like routine surveillance, enhanced surveillance to ensure that infectious diseases, not only infectious, public health events are detected as at early enough. Now, I also want to say that monkeypox should not be tagged as a disease in Africa. A lot needs to be done. I want us to also remember that the origin of the ongoing outbreak is not yet known. The primary or the index case, we do not know how. And we had the smallpox pandemic, which ravaged the whole world, okay? And it wasn't limited to Africa. So while we respond to this outbreak, it's important to have that open mind to know that perhaps there might be other things about this outbreak which has not been known. I perhaps believe that's one of the key points in which FEC was declared for monkeypox, because there are quite a number of unknown. So let's not just assume that this is a disease of Africa. A lot of things have changed, and not only monkeypox, a lot of emerging and re-emerging diseases have been detected early. So there's a need for that openness in surveillance for infectious disease. And then community engagement and social research is also very important. Data sharing should not be overemphasized within country. I've had to deal with colleagues from different countries in the course of responding to monkeypox exploitation and all that. And I know that a lot of the point is many countries love to share data when it's want to share data when it's going to be used for their advantage, you know. So, but there's a need to know that an outbreak or an infectious, a public health threat anywhere is a public health threat everywhere. So we need to be more open in sharing data within ourselves, within nationally in countries, and also, especially for instance, maybe sharing data with WHO, for instance. Implementing IHR should not be when it is convenient, you know, or when it is to our own advantage. We should do it in the global health interest. I think I'm going to stop there. Thank you.
Thank you. That's a good point. Viruses don't respect international borders. Clearly, monkeypox is not a pathogen of just Africa. And we'll have a last comment from Prof. Lim.
Yeah, so the initial question is, you know, why, you know, if Asia has fewer cases, you know, what are sort of the reasons and opportunities? I would say that, you know, since we don't have that much of a, an animal and agricultural sort of industry here, or sector here, a lot of the stuff that we see can be imported cases. So it partly is a function of the volume of travel that we have. And in some ways we have to be careful, you know, not to overinterpret accidents of history as any intrinsic sort of lack of susceptibility, etc. So right now our numbers are low, and that creates a certain opportunity for us to try to prevent this from becoming endemic or established in Asia, in Singapore. And I think part of that is going to be improved case finding, improved diagnostics, trying to get better and faster diagnostics. If you think about COVID, for example, you know, just getting ART kits out to people allows people then to, you know, even if they have atypical presentations, to test themselves. And then I think we do have to focus on prevention. Just because we don't know everything and a lot of unknowns doesn't mean that we don't do anything. We have enough to act with. And so I think it was an important call to sort of reduce the number of sexual partners, reduce new partners, getting the context of people that you do have sexual contact with, so that if you or they develop symptoms, you're able to let people know that they have been exposed. I mean, that's sort of like the social responsibility side of sort of transmission-based precautions for infected people, and you know, contact tracing and quarantine, and then offering preventive vaccination if you've been exposed. Because ultimately we're trying to mitigate risk, but we can't discount non-pharmaceutical, you know, risk behavioral changes, because that can and does make a difference, especially when we are in a setting where there aren't enough vaccines to go around. And then for countries that do have vaccines, how do we deploy that sensibly? Especially as, you know, Dr. Pushpa mentioned, you know, the vaccines are actually still quite experimental. They were intended for a different virus. So we need to sort of target them to people that would benefit most from them. So I, you know, at the beginning of this outbreak, I do travel. I had people asking me, I'm going to Europe for my holiday with my family. Should I cancel my trip? I'm like, no, you don't need to cancel your trip. I mean, there are specific ways you are more likely to catch this disease. And if you're not, you know, going to those events or having those particular sexual contacts, you should just go and enjoy your holiday with your kids. So I think I really appreciate what Dr. Adesola said, which is that sometimes when you report a disease, you are very likely to get shunned. We've seen that happen with lots of diseases. And, you know, we need to be able to encourage countries to report honestly and without getting, you know, countries can get stigmatized just like people. So it's important to encourage that kind of international data sharing, as well as individual case ascertainment by getting the information out and then giving people a sense of hope that they can be treated, disease can be prevented, and they're not helpless in the face of something that can seem a little bit scary. I think there's been a lot of vaccine fatigue after COVID. And so I think we have to be careful and nuanced in our risk communications. Thanks.
Thank you, Prof. Lim. And I think that's all the time we have. This has been a really enlightening discussion, and we've touched on many points. Of course, I cannot necessarily summarize, but a few highlights maybe is that we really, in terms of preparing ourselves, we shouldn't be complacent. Just because Asia doesn't have that many cases doesn't mean that it won't be on our shores. We should be vigilant. We should track surveillance, diagnostics. We should bring in a One Health approach, and also we should communicate the risk information communication to the public and empowerment of stigmatized groups. Yun, I will give it over to you now.
Thank you, Dr. Roki, and also to our distinguished panel, Dr. Pushpa, Dr. Adesola, Prof. Tan, and Prof. Lim. I think it's been certainly a very interesting and insightful discussion, surfacing many of the interesting areas and issues around the monkeypox outbreak. So I'll not tag on everybody's time. So I'll just thank everyone for attending again. Please do look out for future webinars and events on our website at dukenus.edu.sg/COP. So thank you, everyone, and have a good evening ahead. Bye-bye.
Thanks. Bye.
Thanks so much. Have a good evening.
Thank you. Bye.
Bye-bye.